I'm going to talk to you today about the link between acute and chronic pain, a little bit about what we know today, some of the emerging research regarding the specific risk factors that place people at risk for developing persistent post-surgical pain, and what perhaps we can do as anesthesiologists to minimize the risks. No conflicts of interest in this range. I do a lot of work, and you're going to see some of that. What I want to leave you with today is defining the term preemptive analgesia, go all the way back to now something close to 2 decades worth of work in this area, discuss the clinical effectiveness of using preemptive analgesia, and then describe risk factors for persistent post-surgical pain and the concept of preventative analgesia and how that differs from preemptive analgesia. Very different definitions, very different approaches. So we're going to start with a very straightforward clinical scenario. It's actually a patient of mine who's had this exact scenario. 38-year-old, he presented for preoperative evaluation prior to an elective thoracoscopic wedge resection of the lung for treatment of recurrent pneumothoraces associated with multiple pulmonary blebs. And they're bilateral. It's going to be done thoracoscopically. He has persistent, severe, and debilitating chest wall pain following a prior open thoracotomy on the contralateral side. So he's coming to you with pain on the opposite side after an open thoracotomy, now going to have thoracoscopic surgery on the contralateral side. And he is frightened to death that he's going to have bilateral debilitating chest wall pain. So that's the setup. And you're in the preoperative clinic, and he wants to know what's the risk, what can we do to minimize the chances of that happening, and let's go through some questions. So the first one is, all of the following factors are predictive of persistent post-surgical pain in this patient, except first is persistent pain after the prior procedure. Is that predictive of his having pain after this second procedure? Are there any genetic factors that we can identify that might put him at risk? Current use of opioid analgesics. If he's on opioids for this persistent, does that put him at higher risk? And then the surgical approach for the current surgery. No music. I asked for no music. I can't take the music. Okay, so current use of opioid analgesics is not a risk factor. Remember, it's an except, so I probably tricked you there. I'm going to walk you through the data. Persistent pain after the prior procedure is one of the highest predictive factors of pain after this procedure. It's a marker. Chronic pain of any sort, pre-existing, regardless of the anatomic location, is a risk factor. There are identifiable risk factors. We're not sure we can modify them, but we can predict who will have a good pain experience and a poor pain experience based on their genetic profile. Current use of opioid analgesics predicts difficulty in controlling postoperative pain, but does not relate to the development of chronic pain. So that's really the one that's not. The surgical approach for the current surgery does impact. So the magnitude of the incision, how big the incision is, how much damage is done to the nervous system, correlates with the degree of postoperative pain, and we'll see some data on that. Which of the following outcomes is most likely if a single dose of oral pregabalin is given prior to the procedure? So the idea that we're going to give him something ahead of the surgery and try and alter the outcome. And pregabalin is an oral anticonvulsant. So what's the most likely outcome if we give 1 dose of oral pregabalin? Reduction in the likelihood of persistent pain a year out from surgery, reduction in the severity of acute postoperative pain, reduction in symptoms of neuropathic pain, the burning and the lancinating kinds of symptoms immediately after the surgery, or reduction in the doses of opioid needed to provide adequate pain control immediately following the surgery. Which of the following? Sorry, I didn't start the timer. Okay, so again, all over the board. That's good. That's what I want this to be. At the end of this, you'll come out of it. So oral pregabalin has been used. We're going to look at one of the studies, particularly, that used oral pregabalin, but it had to be used for a several-week period of time to have any big impact on the long-term outcomes, and we only have a single study. I'm going to show you that study in great detail. The second is reduction in the severity of acute postoperative pain. It really doesn't change the severity if you use adequate analgesics of an alternate sort. What it does is it reduces the doses of opioids you need to get to the same pain scores. Just reduces opioid. But you get to the same magnitude of pain relief. You just use more opioid to get there, unless you withhold the opioid in some way. And then reduction in the symptoms of neuropathic pain immediately after surgery. Now, this is probably a trick. The patient had some neuropathic pain before surgery. Perhaps pregabalin would reduce their pre-existing symptoms. But it doesn't decrease the immediate postoperative pain, including the burning and the hyperalgesia surrounding the new incision. And that's why I put it in there, to emphasize that they're going to have symptoms of sensitization of the nervous system surrounding the new incision. So which of the following approaches to providing pain control is most likely to prevent persistent post-surgical pain? Is it thoracic epidural analgesia? Remember, it's a thoracotomy here. Perioperative ketamine infusion has been much used for prevention of chronic pain. Postoperative intravenous PCA, the most common form of postoperative analgesia. Multimodal analgesia, where we put a whole bunch of different analgesic approaches together. Or adequate pain control using any of the analgesics. Does it not matter which type of technique we can use? If we use adequate analgesia, is that good enough? Okay, terrific. So I got you spread all over the board. People didn't like ketamine or postoperative IV. They thought that's too commonplace. But thoracic epidurals, maybe. We still have high hopes that our thoracic epidurals are going to provide the best postoperative analgesia and reduce chronic pain. Multimodal analgesia. We put a whole bunch of things together. Are we going to reduce the incidence of persistent post-surgical pain? Scant evidence for that, but some. It's really adequate pain control is the highest predictor. If you're able to control their pain, regardless of the technique you use, your incidence of persistent post-surgical pain is much, much lower. Now, it's a trick question because we don't know if inability to control pain postoperatively is just a marker of someone who's going to go on to chronic pain because they have a genetic predisposition. We all know we struggle. It's just poorly controlled pain after surgery actually might be the marker that this is a person who has a poor pain tolerance and a high likelihood of going on to persistent sensitization in the form of persistent post-surgical pain. But I don't want to be that cynical. I want to think that we can make a difference, and the harder we try, the more likely we are to control pain, so that if we, regardless of analgesic technique, get the pain under control, we'll have the lowest incidence of persistent post-surgical pain. So thanks for bearing with me through that. We're going to go through each of those in detail. What is preemptive analgesia? Well, this starts now nearly 30 years ago. Clifford Wolf is a basic scientist, a physician basic scientist, was at MGH for a long time, now over at Children's Hospital of Boston, where he's head of neuroscience division. And Clifford was doing his postdoctoral fellowship in P.D. Wall's lab over in the UK. And what he was doing was single neuron recordings at the dorsal horn, putting a micropipette into a single dorsal horn neuron in a rat, and then repetitively stimulating the receptive field out in the hind limb of that rat and recording the electrical activity in that second order neuron as the barrage of nociceptive input reached the dorsal horn. And what he was doing the same experiment throughout the course of a day. And the more often he would repeat it, he would get more and more activity in that dorsal horn neuron. And the aha moment that he describes in this paper now 20 years after the discovery, the aha moment was, that's what it does. As you repetitively stimulate with noxious stimuli, the dorsal horn increases its second order firing rate. It winds up. We get spinal cord wind up, increase in sensitization. And now we know that very familiar phenomenon. It's an increase in the gain of at the central nervous system level that says your area has been injured. Protect it at all risk, because tissue injury now has to ensue. So it's our normal protective mechanism, and it's central sensitization. And we now know that phenomenon happens both at the level of the dorsal horn, in the brain itself, as well as at the level of the peripheral nerve, all of which has come out over the last 20 years. So we are all very familiar with this phenomenon in everyday life. You put your hand on the stove, hot stove, you pull it away. Now the area, so you pull it away, there's a reflex arc. Now the area that a moment ago that you could touch lightly with your fingers and it didn't hurt is sensitized almost immediately. and then there's a slow after-burning effect, and you realize that the area has been burned. Now, that's sensitized. That's an absolutely normal phenomenon. The physiologic substrate at the level of the dorsal horn is what we've just seen, the increase in firing of the second-order neuron in response to normally non-noxious stimuli. And we call that allodynia. So this is shown graphically where we have a stimulus. If you pinch harder and harder at some stimulus intensity, you're going to start to experience pain. This is the normal response. And as you pinch harder and harder, it'll get more and more painful until you express it as very severe pain, 10 on a scale of 0 to 10. After injury, this all shifts to the left. It's sensitized. Now, a moment ago it didn't hurt, and a non-noxious stimuli like light touch hurts. We call that allodynia. And a mildly noxious stimulus like a pinprick is now very, very painful, hyperalgesia. So that's the normal phenomenon. Now, what's abnormal is when all tissue healing ensues and that sensitization persists, and we call that neuropathic pain. Persistent pain after all tissue healing has ensued, and it takes many forms. All right, so the anatomy and physiology of pain. Here's just the normal transduction pathway. Now remember, a number of different stimuli, including heat, mechanical distortion, and extremes of pH, can cause an increase in the firing rate of the primary nociceptive neuron. These are primarily free nerve endings in the periphery, free nerve endings. And the transduction from chemical and mechanical stimuli, we now know a lot about the ion channels that lead to that, the vanilloid receptors in heat and cold, and likely a second set of receptors that respond to mechanical distortion. Those then result in increased firing rate in the primary nociceptive neuron, which goes to the dorsal horn, to the dorsal root ganglion, then a central projection to the dorsal horn, a second-order neuron that crosses the midline, ascends via the spinal thalamic tract to the relay station, the thalamus, and up to the cortex, where we perceive pain. And there are multiple projections up here, a set of projections that maps it very specifically to an area of the body. You know it's your left finger that just got crushed, and a second set of projections from the thalamus that say, get the heck out of there, the emotional response. So the other phenomenon is descending modulation. So there are binding centers for opioids in the rostroventral medulla and the periaqueductal gray region. When the endogenous opioids or exogenous opioids bind to these sets of receptor, we have an increase in descending inhibitory traffic that blunts but does not eliminate the incoming traffic, so that you have a decrease in the amount of nociceptive traffic that reaches the brain. This allows us to still function in the face of a severe peripheral injury. So the endogenous opioid system, and we know all this very, very well now, endogenous opioids put at the spinal cord level can bind to both presynaptic and postsynaptic receptors and modify that nociceptive relay station right at the level of the spinal cord, spinal opioid story. All right, now, putting these two together, the idea that if a large barrage of nociceptive input reaches the dorsal horn, we're going to get an increase in gain. We're going to get sensitization. And the fact that we can block peripheral nerves and noraxily, we can block that input. So we can stop traffic altogether using sodium channel blockers, right? Local anesthetics, you block the peripheral nerve. The aha moment there was, what if we blocked all the nociceptive input before the noxious input, the noxious stimulus? So we know where the surgeon's going to make their incision. Inguinal hernia, it's going to be right along the inguinal crease. We can infiltrate with local anesthetic or perform a peripheral nerve block if it's upper extremity pain and block all the nociceptive input. So if no nociceptive input ever reaches the dorsal horn, we won't get that sensitization, and perhaps, just perhaps, we can decrease the overall postoperative pain experience, less acute pain, as well as the propensity to develop long-term pain. That's the idea. We can preempt the onset of that sensitization by giving an analgesic prior to the surgical inset. And now we have 2 decades worth of work and hundreds of academic careers that all go together to say, doesn't work very well. So let's look at it. This is a systematic analysis. It's actually a qualitative and quantitative review. Henrik Kellett and his group published in Anesthesiology almost a decade ago, but it summarizes just as well today, and it's one of the most comprehensive looks at this. And what they did was a cumulative meta-analysis of a number of different analgesics given preemptively. Now, the only difference between these are randomized controlled trials of a number of different types of surgery where the analgesic was given prior to the operative treatment versus after the operative treatment. So, in the case of a non-steroidal anti-inflammatory drug or paracetamol, you simply took the NSAID prior to the incision being made versus at some point after the incision was made, and you compared those two groups. And if there was a preemptive effect, then you would expect better pain control. You would expect that they wouldn't go through the line of unity, but there'd be better pain control in the preemptive group. Now, when you put all those together, it goes right through equity, right smack through the middle. That doesn't mean that NSAIDs don't work. They provide good analgesia. They just don't work any better if you give them before the incision or after the incision. They work well, okay? This isn't about the analgesic approach not working. What about something near and dearer to our hearts? Continuous epidurals, right? The idea you put an epidural in, you dose it with a surgical dose in the preoperative holding area before you even go into the operating room, or immediately in the operating room, and you wait until you have a surgical level of analgesia before proceeding with surgery. Does that work? And this has now been done with a number of different analgesic combinations, including local anesthetics with opioids, local anesthetics alone, local anesthetics with opioids and ketamine. So it's been done a number of different ways. And what we see is there are individual trials that show some benefit or lack of benefit with epidural, preemptive analgesia, but it goes through unity when you put them all together. And these are a number of different surgeries that are all combined. Most of them are abdominal, but a number of these are thoracic. So no benefit of preemptive versus postoperative dosing of the epidural. Doesn't mean it doesn't work. They provide excellent analgesia. That's not the point here. It just doesn't matter whether you dose it at the beginning of surgery or the end of surgery. And there's a caveat there. There's a caveat there. If you dose it too late, you will have poorer analgesia as soon as the patient emerges, right? You dose it too late, you wait for them to emerge, and then it is too late. What about incisional local anesthetics? This is what got it all going. The idea that we have a small incision like an inguinal hernia repair and we put in a local anesthetic right along the course. You can really ablate the entire area. Does it work better? And there were early studies that got all of this going that showed a very strong preemptive effect in reducing both postoperative pain acutely and the development of chronic pain. But when you put a number of different incisional local anesthetics together, almost a dozen here, you see no evidence of a preemptive effect. Now, what Henrik Kellett and his group concluded is important. First, there are some statistical improvements at least one point after the operation for the preemptive effect in about a third of trials, 24 out of the 80 trials. So one point in time, there was better pain control with the preemptive use of the local anesthetic or any of the preemptive approaches to analgesia. But if you put all of the sum of pain scores over the first 24 to 48 hours together, that's the sum experience, if you will, right? You rate their pain over and over and over again, and then you sum the area under the curve over the first 24 to 48 hours. In other words, you look at their real pain experience over the first 24 to 48 hours after surgery. There's no single case where it's significant, just one point in time in many of the studies. So they said this is lack of evidence for a robust preemptive treatment effect. Doesn't matter if you dose before or after, use analgesics, you'll get good pain control in most cases. And future studies should aim right at the idea of the hypersensitivity. How can we prevent that sensitization more successfully through use of other types of approaches other than just pure analgesics? And this was the call for multimodal analgesia a decade ago now. Now, like all good meta-analysis, we're going to do another one, right? We're going to take the same exact group of studies with a couple of additional studies that have come out in the interim, and we're going to do it all over again. Published in Anesthesia and Analgesia in 2005, and this is Philip Lurk, who's over in Amsterdam. He was a resident at the time in Innsbruck, and they did this study and looked at pain scores and did a cumulative meta-analysis. And what they come up with, you can see here, is epidural analgesia. Look, it goes not through unity, but it shows a favorable effect for preemptive use of local anesthetics. And then they came up with a summary table, this take-home message, and I've seen this over and over in talks, suggesting just telling us whether there's a preemptive effect on pain scores, analgesic consumption, and time to rescue analgesic for epidurals. And it says plus, plus, plus is a preemptive effect. If you dose the epidural preemptively before the incision is made, it will reduce your pain scores, reduce your analgesic consumption, and reduce the time to the first rescue analgesic. So what did they do here that's different? This is 3 years later. It's almost the same set of studies. They said significant preemptive effect for epidurals, local anesthetic wound infiltrations, and NSAIDs, but no preemptive effect for NMDA receptor antagonists. Is this at odds with the earlier study that Kellett did? And the answer is no. Their bar, like all meta-analyses, you have to look at the assumptions. It's kind of like a budget, right? You got to look at the assumptions. The assumptions in this latter trial were much more lenient. They said if one score is better at any point in time after surgery, if the first rescue analgesic is even 15 minutes sooner, 10 minutes sooner, if they use even a statistically significant, but probably clinically meaningless reduction in analgesic doses, all of those were considered positive. And that's absolutely true. But which scores is it? It's the patients who have epidurals in a number of the studies where they weren't dosed until they emerged from surgery in the post-anesthesia care unit. And which score was higher? The first one, right as they're dosing the epidural. So the take-home message for me here is use your analgesics before emergence, and your first few minutes in the recovery area as patients are regaining their ability to report their pain will be better. They won't have higher pain scores. That's really the only difference between these two studies. All right. So why doesn't preemptive analgesia work? So there are a number of different reasons that we've come to learn over time, and they're really nicely summarized by Katz wrote this opinion piece, really, in anesthesia and analgesia. It's something of a review, but it is more of an opinion piece, and it really summarizes nicely what our current thinking is about preemptive analgesia. You know, first of all, the somatosensory system occurs. This sensitization of our nervous system occurs both centrally and peripherally. It occurs at the level of the peripheral neuron. So even if we block all input somewhere in between, when that block wears off, there's peripheral sensitization that's going to take over where the central sensitization left off. There's complete elimination. The idea that we can completely eliminate nociceptive input to the spinal cord throughout the entire postoperative period is just ridiculous, right? Your block's going to wear off at some point in time. You're not going to maintain a surgical block for the first 30 days after a colectomy. At some point, nociceptive input, that peripheral sensitization is going to be relayed to the central nervous system. Now, a number of really neat studies were done by Clifford and his group. Joachim Schultz is a neurologist in his lab. They actually did a sciatic nerve block and then a peripheral incision, and they maintained a surgical level of sciatic nerve block for 30 days. And they showed sensitization centrally anyway developed. And what they showed in that is that circulating mediators, so we have both peripheral sensitization, central sensitization. Even if you cut the nerve, nothing reaches, no neuronal traffic reaches the spinal cord. There are these circulating mediators. IL-6 is probably one of the most important that reach the central nervous system and cause it to be sensitized anyway. So we have a pretty robust system for producing this sensitization that will trick anything that we can do in the short term postoperatively. And that's likely why it doesn't work. So what do we have to do? We have to shift our focus to preventing the process of sensitization in a more robust way than reducing nociceptive input to the spinal cord. And we'll talk about that toward the end. All right. Now let's shift to the other end of the spectrum, where we have a lot of information. We know a lot about what goes on, and we know a lot about risk factors. And that's persistent post-surgical pain and the risk factors, as well as possible areas where we might be able to prevent things. The first thing is, during my career, this has all emerged. We didn't know much about persistent post-surgical pain. Probably the biggest reason is we just didn't ask our patients. We didn't go out and ask, do they have pain in a systematic way? A large number of these studies have come from Scandinavia, where we have captive audiences, right? We know the entire population that had a certain type of surgery. We also have a population that tends to return questionnaires. They have 80, 85, 90% return of the questionnaires, as opposed to Americans, 10, 12% we're lucky. So the studies in Scandinavia are very, very well done, and they have a high response rate. And here's what we've learned. After all of the most common types of surgery, persistent pain, chronic pain, persistent pain in the area that's been operated on is extraordinarily common. And you can see just any type of pain in these questionnaires, upwards of 30% in many of these. Coronary artery bypass grafting, 30 to 50%. Thoracotomy, 30 to 40%. Even cesarean section as high as 10% persistent pain after that in the area of the surgical incision. What about pain that's disabling, right? So what? You have a little bit of pain in the area, it's a little sensitive, you know, get over it, right? Persistent disabling pain, that means it's more than 5 on a scale of 0 to 10, and they're still seeking medical treatment for the pain, specifically for treatment of the pain. It's so bad, they're still going to a physician for treatment of that pain. And what you see is we knew a lot about thoracotomy, 10%, right? Because that's the big high-risk one. Thoracotomy, intercostal incision, you damage the intercostal nerve, we knew a lot about it. But look at cesarean section, 4%. That's extraordinary. 4% persistent disabling pain in the area of the surgical incision that's lasting 6 months or more. So this problem is extremely, extremely common. And in that table, there's also an estimate of, based on current surgical volumes, and I put that in the refresher course manuscript there for you to look at. All right, so now what are the risk factors? Here are the risk factors we know, and I'm just showing them graphically for ease here. Number 1, surgical nerve injury. The magnitude of the insult correlates very well with the probability of persistent post-surgical pain. And there's a really interesting story that dates back to the beginning of thoracoscopic surgery. Generation 1, kind of the first generation of clinical instruments used for thoracoscopy, were large trocars that were put in the intercostal space. And the idea here was to have a small incision, not a lot of postoperative pain, because we know those intercostal incisions are incredibly painful, and that we would reduce the incidence of acute postoperative pain by making a small incision. But the trocars were very big, and they were placed between the ribs in a way that actually caused more nerve injury. It was a larger crush injury because they put a trocar between and it pushed right against the neurovascular bundle and crushed it. A partial nerve injury, exactly what you would do in the laboratory to create chronic neuropathic pain very predictably. And they had a very high incidence of pain. And if you look closely at what your surgeons do with thoracoscopy now, there are nerve-sparing techniques. There are retractors that allow them to pull the ribs apart, put the trocar through, the ports through without any pressure on the neurovascular bundle, and they're very creatively created. And now we have a lower incidence with the thoracoscopic instruments than we do with open thoracotomy because of the use of those nerve-sparing techniques. But it's a hard lesson that was learned early in the development of the very first kind of endoscopic surgeries. So magnitude of the surgical insult is very important. And I guess the ultimate evolution of that is natural orifice surgery where there's no cutaneous incision at all. It appears as though you can cut through visceral structures and have a lower incidence, but not zero, a lower incidence of neuropathic pain when we traverse visceral structures than when we traverse the skin. All right. We've done a lot at the dorsal root ganglion and the dorsal horn, but recent studies have really focused not on the neuronal structures that conduct the nociceptive tractate, right, the primary afferent and the secondary neuron, but on the microglial milieu surrounding those nerves, which have a very important role in causing this sensitization. So excitatory purinergic neurotransmitters are secreted by these microglial cells, and they do cause sensitization, and it's a brand new target for looking at how we might modify this sensitization process. So if we're not sure where it's going to go, it may be small molecules, it might be monoclonal antibodies directed as infusions directly toward the dorsal horn that prevent that sensitization. All right, the relay stations, I won't talk much about the relay stations or cortical centers, but genetic effects are very, very important, and we now have some 7 markers that are well proven to be predictive of pain experience, both pain preventative polymorphisms in the genetics and pain protective, pain sensitizing and pain protective. All right, so now let's switch gears. What do we do? What do we do in the interim? So we know about chronic pain, we know about the risk factors, we're going to talk about modifying those. We know a lot about preemptive analgesia and how inadequate it is. what can we do to move from preemptive, the idea that we do one thing very acutely in the perioperative period, to preventative analgesia, where we put a number of different things together and we think about timing those interventions over a much longer period of time in the perioperative realm to reduce postoperative pain. So, potential targets, we talked about surgical technique, we talked about preventive and aggressive multimodal analgesia, and I'm going to show you some studies that sort of hint that we might be able to make a difference. And then we'll end up with symptom control and disease modification at the very end here. So, I'd like to highlight this one study, and I've done it for a number of years now, and I'm still looking for a better study. It's an older study, it's 2005. It just still highlights the idea of how we need to conduct these. It's by Patricia Lavandame, and she took 85 patients undergoing colon resection and randomized them to receive intravenous, epidural local anesthetic with clonidine and sufentanil. So multimodal, putting a lot of things together, clonidine, sufentanil. All of the patients also received anti-hyperalgesic, quote unquote, dose of ketamine intraoperatively only, 0.5 milligram per kilogram per hour. That was it. Just an intraoperative dose alone. And then she looked at VAS scores, analgesic consumption. She actually measured the area of hyperalgesia surrounding the incision, how much sensitization there was. And then residual pain, most importantly, residual pain from 2 weeks all the way out to 12 months. So the idea that as anesthesiologists, our studies are going to be limited to 2 days is really ridiculous. We don't make a big difference in the long run. We can control pain very well, but those studies are already in the bag. What we have to do is really extend the period of treatment and observation. So I'd like for you to concentrate on just the top of this. It's a complex table that says what the treatment groups were. But the idea is pretty simple. Group 1, everything was intravenous. Group 2, intra-op was intravenous and post-op epidural. Group 3, epidural intra-op and post-op. And Group 4, epidural just intra-op. So the last 3 groups all had epidurals, either intra-op, post-op, or both. And the first group had everything intravenously. All of the same types of medications were given. Look, 0.5 milligram per kilogram plus a 1/4 milligram per kilogram per hour of ketamine. They had intravenous lidocaine if it was an IV group, or epidural bupivacaine if it was an epidural group, both intraoperatively and postoperatively, and then sufentanil and clonidine in addition. And here's the postoperative use of epidural and intravenous patient-controlled analgesia. So this is just PCA, the mean number of pushes on the button, if you will. And you see if you have everything intravenously, that's group 1 here, they use a lot more IV PCA morphine. If you use an epidural, even just intraoperatively, you're going to reduce the amount of IV PCA you need in the postoperative period, and for up to 72 hours after colectomy. Pretty interesting. But here's what's really interesting, and this is residual pain starting at 2 weeks and all the way out to 24 months, or 12 months, 1 year after here. So no pain, and residual pain requiring treatment. Remember, Group 1 had everything intravenously, no epidural at all. Groups 2, 3, and 4 all had an epidural. Groups 3 and 4 had intraoperative and postoperative and just intraoperative alone, and they had no patients with residual pain out of the year, which is pretty extraordinary. Now, this same approach, if it were as simple as putting an epidural in, giving them some IV lidocaine and some intraoperative ketamine, and then continuing it postoperatively, we all could do that. We all would have done it 5 years ago, 7 years ago, whenever this came out, because it would have been repeated multiple times. There have been confirmatory trials in multiple different surgeries, including thoracotomy, and there have been those that refuted that, including in colectomy alone. But the concept is there. When we do an analgesic trial, it's going to take more than just a simple epidural. It's going to take more follow-up than just 72 hours of follow-up. And the important outcomes are at a year. Our patients care about this. Remember, if your Press-Ganey scores or your HCAP scores for the hospital have anything to do with it, what's the most important determinant of a patient's post-op pain experience? Is it whether the epidural works or not, or the PCA works? Is it their pain scores that they report in real time? No. Patients can report extraordinarily high pain scores and not remember that at all later if they got very good attentive care. It's really their relationship with the nursing team and the whole perioperative team on the floor that determines what they report even a week later. And that's the important part for us is controlling acute pain isn't our biggest task. It's really what can we do in the perioperative realm that really impacts on long-term outcomes. So that's the emphasis there. Is there anything else out there? There are a number of different studies. This is one of the best done. And in the interest of time, I just show a few studies that are examples here. This is done by Kumar Bhuvanendram at Rush, and he looked at total knee arthroplasty Prospective randomized controlled trial, extremely well done. What did they do? They randomized 240 patients, a big study in the realm of chronic pain, a tiny study in the internal medicine world. 300 milligrams of pregabalin, Lyrica is the brand name there, an hour or two prior to surgery, total knee arthroscopy, and then 14 days postoperatively, and they slowly weaned the dose down. Okay? What did they want to do? They wanted to know if giving pregabalin would reduce the incidence of post-surgical neuropathic pain measured 3 and 6 months after surgery. And it, in fact, does do that. You see the incidence was 0% in the pregabalin limb and somewhere between 8 decreased to 5% in the pregabalin group. Now, this wasn't without its problems. These are elderly patients, and pregabalin has cognitive adverse effects, and they were very, very frequent in the patients who received the pregabalin. That's dizziness and unsteadiness of gait. There were no falls in this, but I don't think that would happen if you had a much larger population. And this was really limited by the low incidence of chronic pain. Total knee arthroplasty is not one of our biggies. We don't have chronic pain after total knee arthroplasty in the majority of patients. But it proves the point. It gets you in the idea of saying, how would we really modify what we do to make a big difference? And it's continuing these types of multimodal analgesics longer term and working with our surgical colleagues to design those. All right, now let's turn to kind of where we are current day and perhaps a little bit into the future. First of all, we have genetic predictors. This is a beautiful study that was published in Nature Medicine in 2006. It's by Clifford Wolfe and Mitchell Max, two very prominent neuroscientists in the pain world. And they worked with the pain group. Bob Griffin was a resident. He was an MD PhD at Harvard. He ended up doing our residency and then our pain fellowship. This was his work. And what Bob did was he took rats, normal rats, and rats that had had a surgical incision created 24 hours later, and he homogenized the dorsal horn and looked for genetic expression, a gene-wide analysis of what types of genetic products were upregulated after an injury. And they came up with a number of gene candidates. Okay, so that's how they figured it out. They had an animal model that said these gene products are upregulated at the level of the dorsal horn. So that's where they came up with their library, and they came up with those that went up 20-fold or more. Gene expression went up 20-fold or more after an injury. And then they went to a library of human DNA samples that also had a postoperative pain experience, and that was the main lumbar spine surgery registry. And they had 7 things they were going to look at. This was the 7th one. They were about out of money, and it's GTP cyclohydrolase. It's a key enzyme that's involved in tetrahydrobiopterin synthesis. So let's look at what that's about. So here's the BH4 pathway, tetrahydrobiopterin. It's a key enzyme in production of nitric oxide synthetase type of enzymes, as well as the monoamines that are involved in neurotransmission. And what we know is that levels of this enzyme are increased after injury to the somatosensory nervous system. So this compound goes up. Production of this compound goes up, number one. Number two is this enzyme, or this cofactor, is important in serotonin, dopamine, epinephrine, norepinephrine, and nitric oxide synthesis. So there are compounds that are involved in neurotransmission, particularly somatosensory neurotransmission, that this enzyme makes a difference for, this cofactor, tetrahydrobiopterin. And we know that if we have excess levels of this tetrahydrobiopterin, they causes pain. Increased levels of this cause pain. And it's likely through excess production of neurotransmitters. So that's the story that we know. And here's what they found. So they took, remember, they were looking specifically. They had an idea that this enzyme might be important in pain and somatosensory signaling. That's all they had, a little bit of a signal from animals. And what they had was a collection of samples, blood samples from patients who had undergone lumbar discectomy in Maine, the Maine Lumbar Spine Surgery Registry. But they not only had DNA samples, they had a nice catalog of the patient's postoperative pain experience. How much pain did this genetic sample, here's the phenotype, their post-op pain experience after a pretty standard discectomy, lumbar discectomy. And that's what they looked at. So they did genetic analysis, and they zeroed right in on this BH4 gene, and they found that this single nucleotide polymorphism, if patients had, the patients who had 1 or 2 copies of this were conferred with a pain resistance. So if you have upregulation of this particular SNP, what happens is your frequency of pain immediately post-op is much lower. See, 2 copies, a much lower frequency of pain than just 1 or no copies of this single nucleotide polymorphism. So basically, we have a genetic marker that says if you've got 2 copies of this gene, you're going to have a great day after surgery. Tylenol for you alone. Okay? So that's essentially what it comes down to. And now we have a number of other markers that have been identified that can predict pain. So what do we do with that information is what I ask you. If we can genetically profile someone in the preoperative clinic, what can we do with that information? And trials are now underway, a number of trials that we're doing looking at blood samples and cataloging the postoperative pain to see if we can actually, if we know that they're going to be a low or a high pain responder, can we change their management in some way to more effectively treat their pain? Or is it just that's the way it is and we can predict who's going to have a bad day? I don't know that. So some of the things that are coming down the pike are use of stem cells, and this is a big discovery program that we have. We've taken patients who have a specific type of pain, diabetic neuropathy, and we've taken skin fibroblasts, de-differentiated them, re-differentiated them into nociceptors with the idea that we can do high throughput drug screening in vitro with a cell that's derived from a patient with a particular type of pain. We've very closely characterized their diabetic neuropathy. So that has a lot of, I think it has a lot of potential for very high throughput screening, and that's one area where we're working, the Harvard Stem Cell Institute. The other I just told you about, genetic profiling. We're doing genetic profiling of patients who are having specific types of surgery and trying to figure out if we knew ahead of time whether there were a high or low pain responder, we could modify that. And then finally, this preventative analgesia may take the form of either a specific inhibitor at the level of the dorsal horn. For us, it would probably mean infusing a compound in the perioperative period. It probably won't be anything sexy like noraxial delivery, but an IV infusion that decreases the glial cell role in wind-up and therefore decreases the level of post-op pain. So to conclude, preemptive analgesia no more effective than traditional approaches to perioperative pain management. Doesn't matter if you administer the analgesic before or after the incision is made, but you damn well better administer it before they emerge from anesthesia, or that first pain experience is going to be pretty bad. Persistent post-surgical pain is incredibly common, far more common than we ever would have appreciated a couple of decades ago. Aggressively suppressing the symptoms of pain at the time of surgery probably is inadequate to prevent chronic pain. Although I wouldn't walk away from the patient, you can't control pain, we ought to do everything we can, because if they have a poor postoperative pain experience, that sure does predict pain down the road. But it just may be that some patients we can't control pain very, very well. Treatment should be targeted at the progression of these neurodegenerative mechanisms that we call neuropathic pain, and I've outlined how we go from acute to chronic. Today, we're left with putting a number of things together in ingenious ways and testing whether or not those combinations work. But tomorrow, we're likely to have a whole new set of compounds that we can bring to bear on this problem. Thanks very much. And I'm happy to take questions. Stunned by silence.
Just a simple question. We all have patients that say, oh, doc, you got to give me a lot of pain medication. It doesn't work on me. How does that correlate to reality?
It's absolutely true. There are varying, so if you're getting out, can I tell whether the patient's gaming you because they like the euphoric effect? I can't tell, but what's it to you? I mean, you know, you're going to see him for 24 hours at the most, maybe 48 hours. I say, don't argue in the acute postoperative period, get their pain under control, even if what you're doing is giving them euphoria and sedation. I think that otherwise you're going to just argue until you're blue in the face and you'll be miserable and your patients won't be very happy either. But that doesn't mean we should set them up for chronic long-term use of opioids or addiction down the road. If they have an addictive disorder, we should recognize it. You can't really address it in the perioperative period very effectively, but you sure can address it before they leave the hospital. So if you're involved outside of the operating room, that's where you're going to make a big impact. When you're helping the surgeon to figure out what analgesic regimen to put them on and how to establish follow-up in an appropriate period so they don't get stuck on these opioids ad infinitum. That's where we don't do much, I don't think, in the immediate postoperative period, but before they leave the hospital, you have a huge chance to impact on the long-term use of opioids.
Keith Candiotti, University of Miami. Actually, we haven't publish it yet, but we did a study where we simply asked the patients, are you going to use a little, medium, or a lot of morphine? And the patients who said medium and a lot of morphine predicted pretty much how much morphine they were going to use based on the group. My question's on smoking. We've noticed in multiple trials, and it's been reported before us, that smokers use significantly more opioids in the postoperative period than non-smokers. Do you believe that this is nicotinic related, epigenetic, mechanistic?
I have no opinion on it. I think it's not a big problem out there in the literature, but I have to admit ignorance in this realm.
Thank you.
Do you routinely use ketamine in your practice? When do you use it?
I don't think we don't have a routine practice for caring for these patients. I think the opioid tolerant patient is where we use ketamine more frequently. A larger number of our practitioners will use either intraoperative single dose or a continuous infusion, particularly the big spinal fusion type of surgery. But it's not routine we don't have a protocol that we have to follow. Perhaps we'll get there, but a lot of practitioners will use it in that way.
Naveen from Ottawa. Could you comment on the role of opioid-induced hyperalgesia and whether it is one of the important risk factors for developing chronic post-surgical pain? And just to add to them, in Ottawa we do have a standard protocol of mixing ketamine in the PCA to prevent the same thing, what we think, but do you think it's important?
So opioid-induced hyperalgesia is just a whole topic unto itself. It can develop incredibly rapidly with some of the compounds we use, like remifentanil. You can see opioid-induced hyperalgesia as soon as the recovery area, a whole dense literature on that area. I mean, if your question is can we tease out opioid-induced hyperalgesia from poorly controlled pain for other reasons in the immediate postoperative period, I think it's incredibly hard to do. Incredibly hard to do. You can't tell the difference unless you did specific types of testing, including use of ketamine. But we don't have good bedside clinical tools to say, oh, this is the person we need to reduce the opioids. They're all complaining of pain. It's not working. The same dose isn't working, right? I got 10 out of 10 pain, and you've given me 100 of morphine. Hey, it's opioid-induced hyperalgesia. How would you like it if I came along and said that to you in the recovery area? It just doesn't work. It's not a practical. But it may, in fact, be a real problem that we're dealing with. And the only way we'd have to overcome it now is to get to such doses that we either produce some sedation so they stop verbalizing their complaints of pain. In the future, maybe we'll have better things that can bring to bear preoperatively to get rid of the opioid-induced hyperalgesia before they get to the operating room. So I get the question, but I don't know how clinically practical it is.
It's just that it could be a risk factor for developing chronic surgical pain. So
it hasn't been. I see that. If you were to test a patient who's on doses of opioids and you were able to establish, it's tricky to do, but if you were able to establish opioid-induced hyperalgesia. Remember, you've got to take them off the opioids to demonstrate that their thresholds for pain perception are different on the opioids than off, right? That's really hard to do when you've got somebody who has chronic pain and they have a surgery down the way. But if we were able to do that and figure out who had the opioid-induced hyperalgesia, then you'd have to put them back on, reestablish the opioid-induced hyperalgesia, and test down the road whether or not that was predictive of chronic pain. It just hasn't been done. I mean, it's a reasonable construct. High-dose opioids, certainly.
Risk for developing chronic pain.
Risk for poorly controlled postoperative pain. It hasn't been linked to chronic pain yet.
Boris Sekno, Warsaw, Wisconsin. There's a couple of papers, I think out of France, that had orthopedic patients with hip replacement, single-dose ketamine followed by a 24-hour infusion, and they found way less pain medication needs, even a year out. What do you think about that?
Yeah, so they're not randomized. They are prospective observational studies, and they hint at that problem. I didn't show that sort of study. I was trying to let's look at the highest, the best level of evidence. But sure, it's a hint. Okay, but again, I think at this point in time, the number of ketamine studies done, it's probably not that simple. Just running a little intraoperative ketamine, because we'd all be doing it by now. There are as many positive as there are negative studies with ketamine alone as the preemptive analgesic. I don't think it's a bad idea. Don't get me wrong, but I just don't think it's the panacea yet.
Thank you.
All right, thank you very much.